Welcome to the Ortho Joe Show, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. In our world, orthopedic research is king, and current topics from our respective publications are analyzed weekly. Here is Mohit Bhandari from Ortho Evidence and Mark Swinkowski from the Journal of Bone and Joint Surgery.
Well, good morning, Mo.
Morning.
I actually am up a little bit early with my Joe, as I've got to hop on a plane and get over to the Academy meeting, be in the JBJS booth with our team and show people what's going on there. And I wish I could say I was looking forward to another airport experience, but it's spring break here in Minnesota, so airports have just been not a pleasant experience. So
yeah,
I need my Joe.
Well, I can tell you that having just been on an international flight and going one, I'll be heading to Zurich, unfortunately, or fortunately, depending on what you look at, missing the AOS. But yeah, same thing. I just hold my breath, close my eyes, and just hope I can get onto that plane very quickly. And once you're on the plane, you just kind of close your eyes, hold your breath, and wait till you get to the next port and keep going. But I think things are opening up. So yeah. Let's hope.
No question about it. I think that's why the airports are so busy.
Mm-hmm, mm-hmm.
Yeah. Breathe easy through your N95 mask, right?
You absolutely.
So this is one of our what's the latest stuff going on in our respective publications. And so yesterday I picked up the March 16th edition of the journal, and I've got one thing I just want to bring to the audience's attention, which I think is a major accomplishment, and that's the International Consensus Meeting Group led by Jay Parvizi has now published their extensive work on VTE. And we hope to be able to interview Jay about these findings, but basically it's a Delphi process that involved over 600 researchers, all types, orthopedic surgeons, anesthesiologists, chest physicians, etc., and used the Delphi method and reviewed basically every single published reference on VTE and musculoskeletal injury and disease. So it is a huge compendium that has now been published at JBJS, which is a 1-year-long effort. And I hope the audience will have a look at that. It's available at the website. And again, we'll bring Jay on to talk about that monumental effort, which I think is going to advance the clinical management of this question of prophylaxis and treatment. So then, as I was actually unaware, since I think your experience is like mine, I'm kind of unaware of what is showing up in that particular edition because I saw it last 3 months ago. So
right,
I can't
and you don't know
remember.
where it fits into the
So
the slot.
Here I am surprised to see where I got to find the reference now. It is on page 512. A publication from your group on
I think I know the one. I think I know the one.
Intimate partner violence during recovery from an orthopedic injury, and it's fascinating and distressing at the same time. How common this is. I know that your group has been working on this for a decade or more. And then you've published several articles, and maybe you could talk about the publication that kind of resulted in this follow-up publication.
Sure. I mean, and so I would say at Ortho Evidence as well, we have the one I think was one of the important original pieces, and this was an ACE report under the title of "The Prevalence of Intimate Partner Violence in Women Presenting to Orthopedic Clinics," and this was in 2013. How quickly time flies! But it was a very large study. Mark, it was about just under 3,000 women across 12 centers, and really the question just was to have a situation in which they were asked about their prior experiences. And I can tell you, prior to this, there wasn't a lot of data that suggested that. Put it this way, among orthopedic surgeons, there wasn't a lot of data that would convince them if they were potentially skeptical about, well, this is happening in the community, but, my patients aren't coming in, because I would know that. I would know that, they're having these injuries. And as it turned out, that when asked, 1 in 3 women in orthopedic clinics around the world, US, Canada, and a number of other countries, stated that they had at least once in their life had experienced intimate partner violence. Now, remember, intimate partner violence can go anywhere from the spectrum of mental, sexual, all the way through physical abuse to the most serious of types of injuries that, for example, orthopedics would see. 1 in 6 of them had said, I've actually had an experience in the last year, and 1 in 50 had said, I'm actually here because of it. Now, here's the point. In that study in 2013, none of those women who had completed this private confidential questionnaire were asked by their attending surgeon about what was happening. So in other words, it wasn't quite disclosed at that period of time. We could go on for a long time, as I've learned from experts who have helped educate me, that there are a host of reasons why a victim wouldn't disclose something at that first visit. That is the reason, Mark, that the paper that is in JBJS, in my mind, is so vitally important, because that became, in my mind, the sirening to our orthopedic community that orthopedic surgeons are vital second chances in this cycle of abuse, to stop this abuse, or at least help women get help in this particular. And I'm talking primarily about violence against women here. We understand that violence in any form to anybody is wrong and should not be tolerated. But in the context of this study, it was violence against women. And the truth is, if you look at the data that's presented in JBJS, which is, I think, striking, is that there was a percentage of women, more than 10%, I think it was like 12% of women, who actually disclosed after their first visit, which meant the orthopedic surgeon, he or she building a relationship with the patient is critically important, because women over time started disclosing because they felt either more comfortable, it was the right time, and there's a sense of safety in doing so. We don't know the outcomes of that disclosure, but we do know that that's what happened. So in that perspective, it vindicates why we can't just assume that social services will handle this. We can't just assume that emergency physicians will be able to identify a woman. Fact is, only 15 to 20% disclose on the first time they meet a physician in the healthcare environment in the first place. So orthopedic surgeons seeing patients for a long period of time really have this, are really in a very important role and opportunity to do so. That paper in JBJS is so important for that reason.
Yeah. Now, so this is a 9-year interval from when the big study was published and this one.
Yeah.
Do you think that the scripted questions that many of our centers use when rooming patients, do you feel safe at home? That type of thing has helped encourage women to disclose?
I think we tried a number of studies, in which we said, okay, and we asked a number of victims who have given us some insight, and they said what helped them a lot generally was the following: walking into a clinic and having a sense, just by looking around, because you're very, very intensely aware of your surroundings, is this clinic one that's it would be supportive of potentially me mentioning something, or are they just going to dismiss it? So they look for literature, maybe a poster, that not all broken bones tell the same story, or something that would help them understand, okay, they get the story. And really, the opening, it was time. It was just knowing, that nonverbal communication, physician-patient communication, that would suggest that there's an openness to hearing about it. But, something as simple as just how are things? How are things at home? Rather than are you safe at home, gave them the opportunity. It's no different than all the other things we ask. Do you smoke? Do you drink? Do you do this? Do you do that? We have so many things that are just standard. So I think the concept of just simply, is there anything else that I need to know? Anything else I can help you with today? All those sorts of general, what seem to be generic openings, can be interpreted in very different ways, as I've learned from women who are looking at that moment to determine whether they want to say something.
Yeah, so it's establishing a trusting relationship with the patient, like we normally do. And perhaps the good news here is that there is increased awareness in our community, and in the future we can do a even better job at helping to solve these issues.
And Mark, and one thing I will tell you though is that I think you know this, but I'll reiterate it, is that this whole area of inquiry happened during my fellowship year with you back in 2003, 2004, because Sonia, my partner who was with me, was, got work in Minneapolis at the Minneapolis Domestic Abuse Project. And she'd always come back, and I'd come back from the clinic and she'd say, tell me about this pelvic rami or ramus fracture. I go, why are you asking this? I go, in our whole life, you've really never cared about this injury or these injuries. And she goes, oh, because these women keep coming in with us. I said, what do you mean? What's happening? And he goes, well, surely they're seen at the hospital. I said, well, let me go find out. And that led to this whole area of inquiry. So the pivotal original paper that came out in the Journal of Trauma in 2005, back then the Journal of Trauma, I don't think it's that journal anymore, was really looking at the 292 injuries in the number of women who had presented to the Minneapolis Domestic Abuse Project. And in many ways, that fellowship with you was life-changing, but for another reason too.
Yeah, you got immune to the cold a bit more too.
Oh gosh, yes, yes.
Yeah, so I was going to ask you. You've been at this a long time now. What's the direction of your team on this topic now? What are you working on?
Yeah. So now it's been so it went from, and the thing that is so incredibly important about, and needs to be said about our orthopedic fraternity, is that when presented with data, any individual who was potentially skeptical about the importance of being an advocate flipped overnight. No one can argue, they shouldn't have needed all this data, but in fact they did. And orthopedic advocacy, at least in Canada, and I suspect, I know it's happening at the American Academy, and I certainly know it's happening in a number of journals as well, and editors have made it a really important issue that orthopedic surgeons should be, in many ways, involved in the identification and ultimate, assistance of women and men who are undergoing violence of any type. So we've seen that become a massively important issue. The big question, though, was, great, I want to do something. I see this as important. How and what do? I don't have the tools or the comfort level to be doing this. And there was a misperception, Mark, that orthopedic surgeons now who had clinics of maybe that, 50 to maybe even 100, patients through a thing would somehow now just be completely landlocked, spending an hour with someone who would disclose. And that isn't the point. The point is, right, is developing the tools and the support system to allow that to happen. So where we're going next is a program actually led by Sheila Sprague, someone I know who's known to you, but she's a scientist at McMaster now and a faculty there, called Educate. And really it's a program that's online that's creating champions at hospitals and at clinics worldwide. And right now it's being piloted all through Canada, and we're looking to expand it beyond orthopedics, actually, and giving them tools and training to be able to, make their environments and their systems such that you can efficiently help those in need.
Well, that's great. You've made a huge difference in this area, and you and Sonia are.
Oh, thank you. Thank you.
Congratulated for your years of work in this area. So let's switch gears now. You and I are big proponents of large, simple trials, but there are some questions where you're never going to get there, either because of numbers or complexity of the question or some other factor. And there is still, I know you and I both agree, a place for a well-done analyses of existing databases. And I point to this article, which is back a little bit farther, from my colleagues down Highway 52 at the Mayo Clinic, and they used their database on knee arthroplasty, which has been going for decades, to look at the clinical question of what happens to knee replacement, which follows a high tibial osteotomy. As you know, there's been a waxing and waning interest in high tibial osteotomy for treating unicompartmental arthritis through the years, and one of the hesitancies that produced a declining interest was that the knee replacement afterwards would be complicated and not have as good a result. So what they did was they identified in their very large database 140 bilateral knee replacement patients. So 70 patients with 140 knees, and they had one knee which had never had a prior procedure, and the other one that had a previous high tibial osteotomy and converted. And the time from osteotomy to conversion was around 15 years. And these patients were followed for a long time, and the range of follow-up was very long, 6 to 40 years. So there were patients who had their knee, total knee after the osteotomy for as long as 25 years. And then they did validated outcomes, the KSS score, Knee Society score, and they did the forgotten joint score, and then asked patients which knees did they prefer. And fascinating, when you look at the outcomes, the patients, 62% stated that the knees were equivalent at the follow-up, and 19% actually preferred the knee that had had the prior osteotomy. And there was no increase in clinical complications following the conversion. So again, a very complicated analytic type of question, small number of subjects, which is going to make us look carefully at the statistics used and things like that. But I think a valuable contribution, and just points out, I think that there are occasions when databases like these can be used to answer rather specific questions. Now, ideally, if we had 500 subjects instead of 70 with 140 knees, but I think it's valuable, and I'm pleased to see it that the reviewers thought so as well.
Yeah, and
What are your thoughts?
I think you're absolutely right. I mean, questions like this, which is what is the outcome, and are the outcomes of those with prior HTOs and hardware in place, for example, different than those who are having, a primary total knee in this case? In many ways, I think I always was taught that, well, if you're having it's functionally thinking of it as a revision, surgery, even though it's a primary knee, it's in a complicated system. The way to do that really would have been a large observational cohort. You'd have two groups, and you try to balance, and you could use all kinds of things, propensity scoring and all the fancy, methodologies that people talk about. Clinical trials would be very difficult in this just because of the numbers. Yeah. So, I mean, it is really interesting that, that again, the group at the Mayo Clinic has put forth this data, and congratulations to them for doing so. Because you're right, you have an internal control there. Now, that internal controls, as create a little bit of confounding as to, there is the glow of where, if it's because the unit of analysis is the human that's had two procedures. But, clearly you can see where failure is, you can see where complications are. And the mere fact that they say, I don't know the difference in 2/3 of the time, pretty compelling reason that would support your hypothesis that maybe, in fact, it is, techniques have gone very far. And quite frankly, we have to give kudos to the surgeons doing those procedures, that they've advanced those techniques in a way that make it. So, the outcomes being so important and so good.
One of the things that I always point out when talking about the responsibilities of being the editor is that often we publish things to provoke confirmatory studies. So I imagine that this analysis is going to prompt colleagues around the world who have large joint replacement databases to look at this question and tease out the data to see if it's confirmatory. And I think we agree this is not going to be something we can apply an RCT to. So confirming these findings will be very helpful. Yep, absolutely. There's lots of functions for a journal, and one of them is to publish things that stimulate other confirmatory or even better research designs. And that's one of the things I'll be speaking about at the Academy, is that number one point, it's the research question. Needs to be refined, needs to involve colleagues that give input before the procedure, the research can be successful.
It's funny that you bring this up, because I've been thinking somewhat on this topic of problem solving versus problem finding. And I think, we spend a lot of our time, and we teach our trainees and residents, they get all the books, and then they see a 5-volume of whatever the flavor of textbook you're reading these days for orthopedics, and they think, my goodness, like that is all of orthopedics. At our age, we start thinking, well, actually that's just a fraction of really what we know. The majority of the stuff we don't know. And it's really all the other stuff that is really important, because that's where our future is. That's where our field is. That's where the American Academy and all the other major groups and JBJS are looking to, stimulate questions. So I think if we stimulate questions, we're doing a good job.
Yeah, absolutely. And you bring up the fact that it's 20 years since you were here in the Twin Cities doing a fellowship. Time has flown, and
I can't believe it.
So many very important contributions to our field, and I look forward to another 20 years of collaborating. So,
can't wait.
Okay. Thanks, and I'm going to finish my coffee and head to the airport.
I'm on my second, so I'm ahead of you. So
you're always faster and better than me. Have a great day.
All right, you too. Take care.
Bye.